Дорогие коллеги,
Distinguished colleagues, it's really hard to imagine the real importance of our event this afternoon. Our task today, together with Professor Govorov, is to distract you and get distracted from our everyday routine and to deal with those specific issues for this session. In the final analysis, this entire conference is for those people who need to deal with some of their medical issues or questions. All right, and Alex needs to get translation. Every day we keep answering questions that are supported here in Russia by clinical recommendations. If we shut our doors, it will be quieter in the auditorium. If you could help us shutting the door. In light of that, since I'm this chief expert in this subject, I'm sitting with my back to some of you, and I have to explain to all of you what I know, what you know, and Alex needs to know that as well. Are you getting the translation? Here's a patient, comma. Then we have a doctor that has certain knowledge, a doctor that checks this knowledge, having some clinical recommendations, the physician, the doctor that uses this knowledge together with clinical recommendations, and the doctor who optimizes the journey of this patient. We are quite experienced. We have heads of our departments. I know all these guys. We want to be honest about that. We know that exhibition is one thing, but in reality it's always different. But if we think carefully, if we compare what we had 3 to 5 years ago, we all understand very well that together this journey, this path between the patient, the doctor, what the doctor knows, clinical recommendations, then supporting the decisions that they make, and then the expert opinions. And here we have people with master degrees and PhD degrees. There are many of them in urology. That's an important point. The organizers asked us to invite some of the leading experts, global specialists on early diagnosis of prostate cancer, whom we have in our country and abroad. It gives me a real pleasure to welcome here a leading specialist in our country, Professor Govorov. Professor, and Alex knows Professor Govorov quite well. And let me introduce to you another well-known specialist, Alexander or Alex Motri, professor of the University of Ghent and founder of the largest teaching and clinical center for robotic surgery in the town of Ghent, Belgium. It's a great honor for us to welcome you here as a pioneer of this practice and also as a specialist who was able to build this kind of training base. But okay, enough with welcoming words, and we will start by asking Mr. Govorov to tell us about about prostate biopsy. I really do ask you to get back to what we had in the Botkin Hall during the opening ceremony, something that took place an hour or two ago. They mentioned prostate cancer 5 times during the opening ceremony, and twice they mentioned robotic surgery. For you to understand, this is a long way for us. This was not an easy journey, so that during such a big conference they used to mention ulcer. Remember, they used to talk about strokes and heart attacks. They would be talking about longevity, and of course they failed to mention prostate cancer in the past. But today they are talking about that. All these people helped us achieve that. Raise your hands if you're urologists. So welcome to Moscow, Alex. For Mr. Motri, it's not the first time you did some surgery in Russia, including our hospital. But Professor Govorov, you may have the floor. Distinguished colleagues, good afternoon. You know quite well, we try never to lecture at such events. We try to organize a live debate, a live discussion. We don't see all of you at the same time, but if you want to ask a question, if you want to make a comment during the discussion, raise your hand. We will give you a microphone, we'll give you a chance to speak up, and we will ask Alex's opinion. This is how we envision this session. We have about an hour and a half. We are going to talk about prostate biopsy. There are quite a few issues that we wanted to discuss, the indications and how you do that. And we will start with this discussion by talking about diagnosis. Early diagnosis of prostate cancer is critical, and we are not tired of it. We keep talking about it. I'm going to give you a clinical example. It's a young man. He is 46 years old. No symptoms in terms of urination. No history in his family about prostate cancer. He was, but he read about Sylvester Stallone and his prostate cancer. This was false news, but this is what I saw online in Russian. And this guy learned about PSA, and he comes to his urologist with a question: what is he to do? Let's ask Alex. Here's a clinical case introduced here. What could you recommend to this person?
What can we say to this patient?
So first of all, thank you very much for the invitation to come here. I would like to say hello to the audience. So you asked me about this 46-year-old patient. So the first question we should ask: should we screen the people, and from what age should we do it? But if one single person is coming to you, 46 years old, we should first question what is his PSA, what is the rectal examination. I believe this is the first thing to do. And besides that, depending on that, we should think about adjuvant or more diagnostics like MRI, I believe.
Спасибо большое.
All right. All urologists in this room, if they have this kind of patient, we will tell this patient, let's measure PSA. Let's start with the simplest thing, get the PSA results. But does this patient even need PSA? Even that is in doubt in recent years. And there were some screening trials. There was this European study that has shown that it's good to have prostate cancer screening. You reduced mortality. But at the same time, an American study was published that has shown that during screening the mortality doesn't become lower, to summarize it in a simplified way. If we look at the data that were shown at RSPC, do we need to get the states in PLCO study? The situation was not very clear. And before I show you the next slide, let me ask Alex. This PLCO study, the American study, how has it impacted the work of urologists in Belgium?
A huge impact, because sorry, is that better like this? Okay, so sorry for that. So this has hugely impacted the way of doing screening, yes or no, because the KCE, which is the governmental body who decides what should be reimbursed and not, doesn't want to reimburse PSA screening anymore. So what is the end result is that we see worldwide that where mortality for prostate cancer was going down, now we see a slight increase. And this is because we are doing less screening than we do before. And this is hugely because of this, let me call it quite false study, because we probably know that this was a population screening, and they have compared two groups, where one group got screening and the other one didn't. There was an independent study team that reviewed these results, and basically the non-screening group was screened as well as the screening group, but they didn't know about it. They went to their own urologist.
Ну, это очень важный комментарий, дорогие.
That's an important comment. We all remember quite well the attention paid to that PLCO study. And Dmitry was receiving letters to stop prostate cancer screening here in Russia. We had to respond to those letters. I'm still quite surprised. There were so many publications about that study. And then Journal of Medicine had this tiny little article of a page and a half, which said that PLCO study had these errors, and the results were misinterpreted, and that most of men in the reference group, in the control group, they still had some access to PSA. And I already mentioned that in one of the auditoriums here in Russia. I want to ask Alex, here in Russia, we never had screening. We never had any screening per se as such. In our country, in the past, we had this what we call early diagnosis, but only at the very beginning of it. And when specialists came to me here in Russia asking me questions, let's cancel screening. In the country that never had screening before, I understood very well, but it's not the screening that's going to be cancelled. They're going to cancel the early diagnosis. So I was against that idea. I said, don't touch this topic at all. And now, 4 years later, we get these results that tell us that if back then we had stopped screening / early diagnosis, remember we discussed it before, had we stopped it back then today we would have T3, T4, 70% as what we had 10 or 15 years ago. Govorov will keep talking about it, but what's your opinion about what I just described?
Well, let's say that in Belgium and in the whole Western Europe, if I may say, even though governmental bodies do not really support screening because of false data we know now, most of the people do screening, fortunately. And all the urologists do promote screening, and fortunately, most of the GPs are doing this, but I know, let's say, about 20% of GPs follow the guidelines of the KCE and do not perform any screening anymore. And I have seen terrifying patients who come with a PSA of 130, metastasized disease, 52 years old, having seen only last week. His question to me, should I sue my GP by not having done a PSA screening on myself?
Все это слышали.
I hope you all heard that. Let me repeat if you not heard it, or if you think that Motri will not say anything important. Look at the situation. Here in Belgium, a guy, 52 years old, with PSA of over 100 metastasis, and he keeps asking, shall I sue my GP, my general practitioner? You can believe him or not, but yesterday I had a surgery with a patient. He had PSA 35. Is Mr. Kalantarov here? He had PSA of 35. Who asks me, I am 69 years old. They never did PSA with me. Who should have done it? And one of our heads of departments sometimes tell us, Dmitry, why do you say that GPs should be taking PSA? Let just urologists do that. But it's done to caution you, to protect you from at least one such patient per year. What if something happens? We're all human. And he would say, why wasn't I tested for PSA, even though I know our Moscow urologists and Russian urologists, but there's this danger every day of being sued or criticized. That's why we delegate PSA to general practitioners and then to refer them to us. If we need to do too much PSA, and sometimes it's necessary. It's not just in Russia, the same situation in Europe. And of course, we want the patient to find out about PSA that even exists, not just from urologists, but from someone else, from GPs, on TV, from a billboard near the road. Now the European Association of Urologists, the clinical recommendations of which we use, we sometimes argue with it and sometimes we agree with it, but it says to us that in the ideal case, we need to explain to a patient what kind of test that is PSA, what are its advantages and problems, and determine the group of risk, and that determines the frequency of our studies that we are going to prescribe. Last year, considering all the data on screening protocols and the studies related to prostate cancer treatment, BIOT and PROTECT studies, we're not going to go into detail, but they issued a special document, a policy paper of the EAU. Download. It's available online, and get to us. We'll give it to you to read. It has been translated into Russian so that you know. It's quite important. All the documents of the European Association of Urologists, and since September, we're all full-scale members of the EAU. Raise your hands if you are a member of EAU. It's important that we're here, and it's your document. It's the kind of document that we use here in Moscow, for sure, because we are part of that story. What will you tell to the patient? We will tell the patient, let's get the PSA test. Let's imagine that PSA was conducted at the age of 46. It's 2.7. We did the rectal exam, a slightly increased prostate gland, no pain, homogeneous, no compacted parts, but his first PSA is 2.7. What will we do, Alex, in this case? with PSA 2.7, 46 years of age.
First PSA taken, I suppose,
Да.
so we cannot have a look at the PSA velocity. I believe we should, the first thing we should do is examine that patient, see how large his prostate is, but we know already that a PSA of 2.7 in a 46-year-old patient is highly suspicious. So I would look at the PSA density, but very probably this patient will need more examination, and we could say, let's check and take other biomarkers and urine like kallikrein, or go for pro-PSA, or check at free PSA. To be honest, I'm not really doing that, because we have now a wonderful tool called MRI, and I believe this is for sure the next step in this patient.
У меня вопрос Матри.
I have a question to Dr. Matri. Here in Russia, in Moscow, we have Prostate Health Index, PHI, which stands for Prostate Health Index, and virtually every lab can do that. What about Belgium? Do you have that?
We don't use this standard, basically for me it has become very easy, because we have a very easy access to an MRI scan, which is not the case everywhere. I don't know how it is here in Moscow, but we have very easy, so we can have that within the week if we want. And so we basically go immediately towards MRI test before we go for invasive biopsy or whatever.
Тест минус 2, тест минус 2 про ПСА – это тест крови.
Test minus 2 pro PCA is a blood test.
Это тест индекс здоровья простаты, перевести нужно как prostate.
So Prostate Health Index. Do you have that?
We have prostate MDX, etc. But we, well, basically, I don't use it, and I know of only very few that use this systematically. Because these extra examinations will not really help us to give us sufficiently safety in helping the patient what way to go. I believe the best way to go, is to go for an MRI. MRI has very good results in showing, let's say, clinically significant cancers.
Видите, какая ситуация? Смотрите.
So you see, how the situation unfolds. I know that in Moscow and in some other cities in the Krasnodar region, the PHI, the Prostate Health Index test, is widely used. And today, this test tells us what is the probability of prostate cancer. At the same time, MRI, that is a technology easily accessible in Moscow. Yes, there is some waiting time when you wait for your MRI results or MRI interpretation. And Alex, one more question to you. So what about this 46-year-old patient? Do we go straight for prostate biopsy? So what do we recommend to this patient with PCA of 2.7, who is 46 years old? What would you do? What would you go for with this patient?
Very clear. We do not do any biopsies before having done an MRI. I believe this is very important. Even with the normal rectal examination, we know thanks to the era of the MRI there are much more anterior tumors than we have ever thought there would be. So for me it's clear when you will counsel a patient with a 46 years old and large PSA, first step for me is an MRI. I would always check a second time the PSA, of course, but I would go for an MRI and then we would go for biopsies, without any doubt.
Очень интересное мнение, коллеги.
We totally agree with Dr. Motri's opinion that we shouldn't go straight for biopsy. And we cannot prescribe rectal biopsy, anti-rectal therapy straight away. It is also wrong. Probably we can go for double-checking PCA test. We can go for a second PCA test because probably there was a lab mistake and that is why our PSA test came out wrong. So we should double-check that. Then we should go for visualization, MRI or something else. There are some alternatives. So my question to Alex is as follows. We'll discuss MRI, but how do you calculate risks at this stage? Will you go for risk calculation at this stage for this particular patient?
Several ways, and you can go for risk calculators, you can go for PCA, you can go for other tests that give you probability. For me, there is no doubt, again, that we should go for imaging as a next step. I, to be honest, have omitted all the rest, and because I believe it not useful and too expensive for what you get for it. I know MRI is not cheap, but I believe it's the best tool we have available today. It's non-invasive. It is not giving any radiation to the patient, and so that's what we do today.
Ну, давайте представим себе, что мы этому пациенту повторно.
Let's imagine we went for a second PSA test. The results came out the same. We used a risk calculator, which is available in Russian, which is based on European research, RSPC. We some time ago translated it into Russian. And if we introduce the data that we have prior to MRI to this risk calculator, then the risk is 10%, and clinically significant risk of prostate cancer is 2%. For some people it will be a lot, for some people this figure will be insignificant. But if we try thinking about our own opinion, I wouldn't be calm, because for me PSA level of 2.8 or 2.7 in a 46 years old is concerning. That is why we go for additional tests. We go for prostate health index, and now we have PCA3 test in Russia, and we would like it to be more widely used. I won't be going into detail about prostate health index, because lately we've been discussing it a lot. We use this test for PSA from 2 nanograms per mil. So these are patients about whom we are doubtful whether we should go for a biopsy or not. Sometimes some Western researchers would compare prostate health index and PCA3, and they found out that sensitivity and specificity was better in prostate health index than in PCA3. So in case of this patient, we went for PHI, and it was at the level of 29 with the normal ratio of 25. We use other risk calculators available at the very same website. This risk calculator uses European data, and in this case, the risk of prostate cancer is 33%, and of clinically significant cancer, it is 16%. So we have totally different figures. And now we move on to the decision that Alex has talked about. We decide whether we will go for MRI or not, or if we will go straight for biopsy. And there's been some changes here recently. An important thing to mention for Professor Matri is that in Moscow, last year, a prostate biopsy system started to function. It was launched. It used 3D gastro scanning, dystrofusion. That is a methodology that is actively used in many European countries. And this method makes it so much cheaper to do a prostate biopsy. It also leaves the decision of going for a prostate biopsy with urologist and Professor Govorov, at the instruction of Russian Urology Association, of Russian Health Ministry, keeps a register of these biopsies. That's just for your information. Many patients have their MRI done for them. And the question that I personally am concerned with is as follows. Let's take Europe or Belgium, that is close to you. Alex, you know it very well. Do all MRI specialists are educated enough that you can trust them?
You're putting the finger on the right spots, dear Dimitri. So this is an old question, because do you trust your uroradiologists, yes or no? And it is indeed very, very important that you have a good team with whom you're working with. I am very fortunate to have two wonderful uroradiologists, and we discuss with each other almost every day on patients. Also preoperatively, for me, MRI has become my GPS to operate on somebody and to define how much nerve sparing we can do and how much we cannot. Also preoperatively I discuss with them, but there are a lot of radiologists who have no clue about MRI on prostate. So this is extremely important what you say. Same thing with CT scans on kidney. So I never trust a radiologist, so I always want to see the data and the images myself.
Ситуация, которая имеет место.
You know, the situation in Belgium is very different, actually. Why so? I remember back in the days people said, well, if only we had ultrasound, we would do ultrasound. Then they said we could go for some other technologies when new technologies appeared. And now, you know what they tell me? If we only had a good MRI radiologist who would be able to tell us what they see there. Because sometimes they make serious mistakes. Because you can do that on your own, but you need a specialist whom you need to trust. We do not want to do 20 biopsies that were not required. You know, sometimes biopsies result in finding nothing. And I would like to tell Professor Matri that we in Moscow, in Russia, we been in very close touch with our teams, with people we work with. That is something that is very characteristic of us. We always want to have this personal contact. We want to keep in touch. Unfortunately, MRI people, they speak a totally different language now. And if there are some other opinions in the audience, please do inform us. I'm speaking here about our everyday work. Of course, there are some experts that we can consult, but we need MRI people available for us every day. Of course, we have gastroscopy for preliminary biopsy and secondary biopsy that I will require in a year. Secondary biopsy, for that end, I will need MRI. And we do that with Mr. Hripun. For secondary biopsy, I will need MRI specialists who know how to work with prostate. So that is what we have now in Moscow.
We have now a real prostate center where we work very closely together with on a multi-specialty basis, and I believe that is extremely useful. And one of the key figures is our uroradiologist. And to be honest, you have, as you have extrovert and introvert urologists, let's be honest, you have radiologists with whom it's very difficult to work with, and others who are very open. To be honest, our radiologists have a lot of secondary and tertiary referrals. They look at all the images I have, also from other departments, and they basically do not get paid for that. So because they are not doing these MRIs. So just to tell you that I'm very fortunate to have these people available. And as you mentioned, I didn't understand everything, but as you mentioned, probably we have now better imaging than we had ever before. We can now see much better with much more reliable results where clinically significant cancers are in the level of wherever in the prostate. And so how to biopsy them, that will probably be the next question, Alex, I don't know. But I believe that MRI has become a cornerstone in diagnosing prostate cancer.
Вне всякого сомнения, мы бы хотели выполнить МРТ всем.
It goes without saying that we would like to do MRIs for each and every of our patients, and we want MRI results to be reliable. And the guidelines of the Urology Association say that if there are no counterindications to MRI, if a patient is not afraid of confined spaces, then we should go for MRI before primary biopsy, which gets us in a very tight spot, actually. Unfortunately, I have some troubles with changing the slide. So today we know that if we want to do an MRI, we need to do that in a special expert center. And as of today, it is still an individual decision. And if we speak about Moscow, not about Russia, only about Moscow, unfortunately, today Moscow healthcare services are not ready to do MRI for each and every patient before a biopsy. Probably we'll get there, but as of now, unfortunately, not every patient gets an MRI. Let us imagine that our 60-year-old gets an MRI. We see some suspicious area. It's a 4 on Pirate scale. And the next question is something that Alex has mentioned already. What we do next? Will we do for transrectal biopsy or transperineal biopsy? That's the picture once again. Or will we go for targeted biopsy only from this suspicious area that has been rated as 4 on Pirate scale? The majority of urologists that do biopsy, they go for standard biopsy, ultrasound biopsy. We try to go for MRI-guided targeted biopsy, not for ultrasound-guided prostate biopsy only. And we know that Alex has brought some slides on the prostate biopsy, and he will speak about it in greater detail when we will be done with this clinical case. So we here in Moscow, we go for hysteroscanning, and we planned to show you some slides about it as well. Why so?
Говорят о том,
There are a number of publications that tell us that you can use other methods of visualization and get all data that is almost as good as MRI. But at this stage, we may stop discussing this clinical case and moving on to biopsy, because our topic of the entire session is biopsy, prostate biopsy. And I have a provocative question to you. There's hardly a person in the room who get up and clearly say or talk about indications for a patient to do biopsy. It's almost impossible. There are so many factors that we need to consider when we make a decision about biopsy. Every individual patient, when that decision is made, turns into a highly individual algorithm approach. PSA, prostate health index, family history, what the wife thinks, what other illnesses the patient has, what are their plans, what does the patient himself think. There are no universal guidelines for every situation. And this is also true about secondary biopsy. When we make a decision about a second biopsy, we already have some data about primary biopsy. We know whether PSA is up or not. We can look at the density. We know about histomorphology after primary biopsy, and we make individual decision. And here, let me ask Alex, we wanted to discuss different types of prostate biopsy, different approaches. You know that you have prepared a presentation about that.
переключить на слайды на...
While we're switching to your slides, Alex, let's find his slides. But before that, let me ask him. Alex, here's a simple question to you. What are we afraid of? What are the dangers? Well, this 46-year-old patient, he has PSA 2.7. What stops us? What is stopping us today from doing upfront biopsy, prostate? What stops us? Why are we so cautious? Why do we have to behave as we do? Is this even correct?
I think this is the question. What should we do there, and should we go immediately for biopsy? What is the danger of it? And so I will have this a little bit in my slides so we can discuss this in a moment. Of course, we always say a little bit laughing, we should take care not to make Swiss cheese with a lot of holes in it. That's a little bit exaggerated, of course, but don't underestimate also the complications that you can have with biopsies. That's number one. Number two, we know that the quality of MRI after biopsy is less good than if you do it prior to biopsy. So if you envision to have eventually curative nerve-sparing prostatectomy done, I believe that there it can be useful to have the best possible MRI images available before you go for that. You agree on this? Okay, so I tried to, sorry, but I don't speak any Russian, so I used Google Translate. Don't kill me if there is something funny on it, because I couldn't check whether that was right or wrong. Let's say 10, 15 years ago, as a urologist, it was very simple. We only had rectal examination and we had just PSA. And these have been for years long the cornerstones for prostate cancer diagnosis. Of course, we should question whether, Alex has already mentioned this a little bit, is this still useful as a tool prior to more invasive diagnostics, if it's still useful, yes or no. When we have a look at PSA, there was a study in the New England Journal of Medicine who has shown that in a PSA level between 3 and 4, up to 27% of patients had the risk of prostate cancer, and 6.7% of them were having a significant cancer. Of course, PSA can be improved using the PSA density and the PSA velocity. That's why probably a yearly PSA follow-up screening could be useful. We also have rectal examination, but of course this examination is very subjective, and sensitivity and specificity of rectal examination on its own is too low to use as a criterion to say we have to biopsy this little hard thing that we feel on the finger. Of course, we have transrectal examinations, transrectal ultrasounds that we all have been using for a long time. Unfortunately, today we basically only use it to measure the volume of the prostate, and we know that nowadays important cancers can be missed, that clinically insignificant cancers are usually only identified by chance, and that about 1/3 of the there is almost in 1/3 a undergrading of the Gleason score. Of course, we can improve the diagnostics of transrectal ultrasound with elastography, histograms, etc. There is now in the EAU guidelines for risk assessments, there is now a strong rating of, in order to avoid unnecessary biopsies, we should offer further risk assessments to asymptomatic men with a normal digital rectal examination and PSA, a level between 2 and 10 prior to performing a prostate biopsy. So, as you mentioned already, Alex, you have the risk calculators, you have the imaging, and there are additional serum and urine-based tests like these nomograms. I will not go into detail, PHI, total, free PSA, pro PSA, 4-kallikrein, urine biomarkers, and MRI. I told you already that basically I am not, and I believe that a lot of urologists in Belgium are not standardly using these anymore, but MRI. So with MRI, we have now much better imaging to see the zonal anatomy of the prostate. You can see the transition zone, the peripheral zone, the bladder much more nicely than we could ever before. Of course, it is not easy, as mentioned by Professor Pushkar, and we need good uroradiologists to help us and to guide us how to determine where there is the high risk foci on the prostate, and especially the Pirates 4 and Pirates 5 are of risk to have significant cancer in it. When we have a look, there have been a huge amount of studies about this. Basically, we can have now a check whether prostate MRI with or without targeted biopsies are better than systematic biopsies for detecting prostate cancer. So we know from this PROMISE study that you have mentioned, Alex, as well, that basically MRI has a very high sensitivity of 93%. Of course, its specificity is only 41%. When we have a look at the precision trial, where they compare the MRI targeted biopsies and standard biopsies, we see now that MRI targeted biopsies alone detect more significant cancer, prostate cancer, than if you would do transrectal guided standard biopsies. And this is a difference of about 12%. So on the other hand, thanks to MRI, you will probably avoid to have to take biopsies in men in about 25%. So in our daily practice, we are performing a lot less biopsies that we used to do thanks to these data. So we are doing much less biopsies, and the chance to find cancer when we take biopsies has risen a lot. So how do we perform these biopsies? Are we doing this MRI target biopsies or standard biopsies? What we have seen basically is that a combination of the two has the best results. And so I believe that together we have about 10% more significant cancers that we can find. So in the EAU guidelines, it states that you should not use MRI as an initial screening tool, but you should use it when you have PSA, rectal examination. And for example, when you have an MRI that is negative and you have a clinical suspicion of prostate cancer, and the clinical suspicion of prostate cancer is low, there you should omit biopsies. On the other hand, when MRI is negative, but there is a suspicion of cancer on the finger, that's where probably you should say we will do a biopsy. Please.
Alex, если
If we get back to our clinical case, 46-year-old patient with PSA 2.7. If we make do an MRI, perineal of 1 or 2, what would you do in that situation?
So this is a very good question. So we know that with PSA, with MRI, I always compare an MRI with a drawing, with a wide wall, with black dots. The more aggressive the cancer, the less the cells look like a normal cell. So the better you can distinguish them. So the better you see them. The less aggressive the tumor cells are, the better they look like a normal cell, and the more difficult it is to distinguish between a good cell and a prostate cancer with low aggressivity. So in your question, 46-year-old with a PSA of 2.7, we agree that this is suspicious, so that we need an MRI. You agree on that? So on the MRI, imagine you have a PIRATES 4 or 5, it's easy. You have to biopsy. Imagine you have a PIRATES 2, he's only 46 years old. Would we do active surveillance in this case? Probably the guidelines would say yes. I would say no. Because if we do active surveillance, you take 30% risk that when you do active treatment, you will be too late. And so in this case, I would counsel this very young man to go for biopsies, because if we see Gleason 3+3 or 3+4, which can easily be missed on an MRI, so that's where I would certainly go for a biopsy.
Спасибо, но мы бы сделали то же самое.
We would do the same. Thank you. We would do the same. It's a very important comment. Pay attention to that, dear colleagues.
Back on the results of MRI when we look at data. So first of all, we have significantly less biopsies to take, which is better for our patients. We will find 20% more significant cancers, and we will have less insignificant cancers. And so MRI reduces overdiagnosis of clinically insignificant cancers and improves detection of clinical significant cancer. So coming back to your clinical case, and imagine he's 66 years old, you agree we would not do a biopsy on this case. So, but MRI lacks 10% significant cancers. So in case of a clinical suspicion, we should go for systematic biopsies anyway. Do you agree on these conclusions on there? So if you all agree and there are no questions from the floor or comments, I would propose that we go to the next question, how to biopsy. How to biopsy is a very, very important thing. We have all been doing transrectal biopsies for decades. And, but we have to be honest today that every single biopsy you do transrectally, you get iatrogenic bacteremia of rectal flora in the blood, in the body of the patient. So every biopsy you take, you have an iatrogenous bacteremia. Don't forget this. Because of this bacteremia, you have 3 to 5% risk of having a urinary infection, going sometimes up to sepsis for the patient, which can be a life-threatening cause. So more and more this is becoming a problem because there is more and more resistant germs going around that are basically resistant to quinolones. So that can be a problem to treat. So more and more when you want to do rectal biopsies, one questions to take rectal wipes before you do a biopsy to be sure that possible germs are not multi-resistant. So there is a problem there. The next problem with transrectal biopsies is that we see many more anterior tumors than we previously thought. Look at these few images just to show you. They all have significant cancers anteriorly that are very, very easily missed. Look at this case, for example. Very difficult to put your needle transrectally into the good position. So we have completely changed our practice. And we are basically, never say never, but in the absolute majority of the cases, we are now taking transperineal biopsies. Today, we are giving them a little bit of sedation, which is the drawback of this, I believe. But there are a lot of data in favor of perineal biopsies. There is the prevalence of anterior tumors that are higher than commonly thought. There is less risk of infection, less risk of sepsis, less risk of rectal bleeding, and the problem of bacterial multi-resistance.
Алекс, скажи, пожалуйста.
Yes, we are quite agree with that, and Mr. Govorov, who teaches at the level of European course of urology, you know, his course on prostate biopsy, we agree with all that. There's one question though, which percentage of secondary biopsies do you do in Belgium today? Percentage of secondary biopsies?
I don't know.
У вас клиники?
Let's say in your hospital.
Hospital, the risk of having to take secondary biopsies has lowered significantly because we combine now our perineal biopsies with targeted biopsies plus saturation biopsies. So we are doing quite a lot of biopsies in our patients. There are secondary biopsies needed, of course, but these are always the uncomfortable ones. But fortunately, the percentage of them has lowered significantly since we've changed our strategy.
Мы говорим, это примерно 10-15%.
Would you say 10 to 15% of secondary?
Повторная биопсия.
Secondary repeat biopsy, that's what we are going to discuss in Moscow at the sessions of Moscow School of Urology in autumn. In spring, we will have something similar to what we had in autumn 2018. In autumn, we are going to discuss how we reduce the number of secondary biopsies. We do quite a lot of them in Moscow. And there's another point that we need to understand very clearly. Today, we do biopsy as an outpatient procedure. And you too, right? And at the same time, in where we have an outpatient clinic or short stay inpatient hospital, we use sedation quite rarely. But now, the question of rectal biopsies will be reconsidered. And here's my second question to you, Alex. How many points of biopsy do you use on average during primary biopsy?
Biopsy, I would say at least 20. So we go for fusion biopsies, number one, but we always take biopsies of the rest. Never say never again when you have a 75 years old or a 55-year-old patient. That's a huge difference. But we combine targeted biopsies with the saturation biopsies.
И еще для лучшего понимания практики, вот
For better understanding of your practice in Belgium, let me ask you two questions. Question one. In your hospital, this perineal biopsy, how many minutes does it take? How much time does it take?
About 20 minutes, but it's under sedation. And so we are now trying out a new tool which is called precision point biopsies, where we do it under local anesthesia. And it takes time to do these perineal biopsies, much more than if you do transrectal. You can do it very easily, very quickly. Here the patient has to come get sedation and so that takes a little bit longer. That's the drawback of doing these perineal biopsies. But it has a lot of advantages, and so we basically stopped rectal biopsies.
а сколько таких больных
And how many patients in your hospital undergo perineal biopsy per year? How many patients?
About 600, approximately.
600.
600 biopsies per year.
Коллеги, урологическая практика у всех разная.
Of course, we all have different experience, and here we have Mr. Satchenko, the head of our short-term inpatient practice. And last year, when he gave us the report on the number of biopsies, what was the figure? Around 1,600 biopsies per year. And our colleagues from the Botkin Hospital, how many biopsies did you do last year? Colleagues, are you here? I saw a colleague from the Botkin Hospital, but unfortunately he is not here now. Anyway, we all have a different number of biopsies, and of course the number of biopsies, they also influence our decision making. I would like to share some information with Alex, actually. It's a very curious bit of information. 25 years ago, am I right, Sasha? Me and Professor Govorov, we designed an automated tool for prostate biopsy that at the same time used 6 needles with just 1 injection. So you didn't need to go for 6 shots. We only introduce a sensor twice. We didn't have to do it for 6 or 8 times. So we did all of these 6 injections, 6 shots simultaneously. And what is this tool that is here on your slide? Is there some special tool for biopsy?
Again, coming back to numbers, you must know that we are a referral center, so a lot of, let's say, home urologists are doing their biopsies themselves. But unfortunately, they are still quite of them doing them transrectal. But in our institution, we have left this almost completely to do transrectal biopsies, and more centers in Belgium are doing so, and I understood that more and more also you and others in Europe are changing this. This tool you see here is the precision point, and it's something that we are testing. My colleague here Tenayer is testing this as we speak, where we do in our consultation room. Basically, we are doing these biopsies based under local anesthesia. So this is a very easy tool that you can use for doing these perineal biopsies under local anesthesia. We don't have any results yet, but it's very promising, so that we could omit even to have to do sedation in all these patients. So here again there is from current opinion. It states that transperineal techniques have little to no incidence of infection, with some investigators omitting even procedural antibiotics altogether. But despite these improvements, transperineal biopsies remain uncommon, up to 0.2 to 6%, which is very low. So that's a little bit about it. So
now, Alex.
Alex, once again, going to some practicalities. In your hospitals, do you give antibiotics to patients who undergo a biopsy, perineal biopsy? And if so, what kind of antibiotics?
They do get 1 pill of levofloxacin.
Одну таблетку левофлоксацина.
That's all.
Just 1 pill, right?
Доза.
What is the dosage?
Normal dose, I don't know, 200.
It's 250 or 500?
250. It's not ciprofloxacin, it's levofloxacin.
Levofloxacin.
Yeah. And you see, there are studies that even omit to give any antibiotics when you do transperineal biopsies.
No, и все-таки я задам вопрос в отношении вот fusion biopsy.
Let me ask you a question about fusion biopsy. Last year, at the Congress of European Urology Association, at the Expo, they showed 20 different biopsy systems, Coelis, Philips. There were 12 of them. So how do we choose? In Belgium, how do you choose your system?
Very, very, very good question. I don't know. I don't think that the best one is still there, is already there. So to be honest, I think that they all have their advantages and disadvantages. And it's very difficult to counsel you there, but the best one is not there yet, if you ask me. We are temporarily, for the moment, using BK, but also this is not always the best you can get, but it's better than anything. Also, we have our own findings that we have the MRI images, we have the ultrasound images, and in our mind we can do the fusion in our mind, but we use now BK.
BK. А когда вы делаете...
Okay, and when you do a fusion biopsy and there are suspicious areas, how many specimens do you take from this suspicious area?
In every suspicious area we take 2 biopsies. But as I told you already, we don't only do targeted biopsies, we always do also biopsies from the rest of the prostate as well. So we usually take how many suspicious areas you have. We usually go to about 20 biopsies for each patient, approximately. Can be 15, can be 30.
Спасибо большое. И...
Thank you so much. And listening to you, I jotted down some things actually formulating them as question. You talked about active surveillance, saying that there are patients who can be candidates for active surveillance. So going back to that, who prescribes active surveillance in Belgium? What kind of doctor? Where does this doctor work? Is it just one doctor, or is it a multidisciplinary team who does that?
Actually, it should go through a multidisciplinary council team, which comes together every week, and there is decided what way to do with what patient. But there is another thing, that's the counseling with the patient. We all know that to live with cancer, and when your urologist says we will not treat it, is sometimes very hard to bear. We know from quality of life studies that the watchful waiting group or the active surveillance group is usually doing worse than if you do active treatment. So don't forget about that. So a lot of people don't want to live with some cancer in their body. I don't say we should counsel them properly and not easily say, well, if you don't agree, we should really take our time to discuss with patients, to discuss the real data of it, and also the risks of it. Don't forget that active surveillance, we must just beware that the pendulum is not going from one side to the extreme other. We must acknowledge we have done too many active treatments on insignificant cancers, let's say 10 years ago. Now the pendulum is moving towards the other side. We are now doing screening to catch a prostate cancer in the smallest possible volume and the least aggressive possible. Because we cannot diagnose a prostate cancer before it is a prostate cancer today. Once we have this, and then we will say we will sit down and relax and not do anything. You should carefully counsel this patient. So when we make a treatment decision, it's first urologist. This is then discussed in the board of the multidisciplinary group, and then it comes back to the patient. But the end decision is urologist with his patient. It's still, the prostate is still the property of the patient, I presume.
Большое спасибо, профессор Говоров.
Thank you so much, Professor Govorov. Thank you so much, Professor Matry. And using this unique opportunity to welcome Alexander Matry here in Moscow, I'd like to say that many of people who are present here today were to RC Training Center. Please raise your hand, those of you who have been there in Belgium. 1, 2, 3, 4 people, 5 actually, in the audience have been there. And we plan, and I'm saying that to everyone, we are planning Russian language courses at the RC Training Center. The first of them will start in April this year. And please, all of you who do robot-assisted urology and laparoscopy, do pay attention to that. And young doctors who speak the language and who would like to do these courses for 2 or 3 days, please pay attention to these courses. But once again, the course will be in Russian, all thanks to Alex Matry. And I have a question to our Moscow urologists. Do you work at a urology? So, Alex, you work in the urology clinic of Ghent University, right?
No, I'm working in the OLV hospital in Aalst, which is a private hospital, but I am an associate professor in the University of Ghent, so we work very closely together with Ghent and Leuven, and I would like to thank you, especially together with your colleagues, for helping us, because to achieve our goal and our mission at Orsi Academy is to improve the way we are performing medicine in general and surgery specifically throughout the world. You are a wonderful example on how to do this, and it is our ultimate goal that we gather top experts worldwide together to help us to disperse this mission, and to be able to do it in dedicated languages, I believe, is another advantage. And I know that you are putting a lot of effort into that, and I sincerely thank you for this.
Нам очень приятно, Алекс, что ты открыл двери лучшего тренинг-центра в мире.
Alex, you opened for us the doors of one of the best training centers in the world. You have 12 robotic machines, systems, just in one place. Operations on corpses and on animals. It provides so much opportunities for people who are going to study there. I thank you all, ladies and gentlemen, for coming here to join us. I thank Professor Govorov and Professor Matri for taking part in this discussion. We have some time for 1 or 2 questions. So, colleagues, if you have some questions, we are ready to take them.
Okay.